want to welcome you all here today. We thank you very, very much for coming. We've got a great program with some just fabulous speakers. Many of them are known to you. But I want to first thank a number of people. I'm going to introduce you to Jim Phelps in a moment, who's our host today. But I want to thank Lisa and Rosemary Baldacci for putting this all together, and the Health Alliance that is behind this, the Alliance, which is very instrumental in assisting in bringing not only this forum together, but to also is very focused on healthcare quality delivery and providing information and services to assist around all the issues of public policy. So thank you, Rosemary and Lisa, for assisting with this and bringing this together. I also want to mention a few folks. Jamie Wagner, thank you very much for the luncheon. John Baldacci, who has obviously been a huge contributor to all the wonderful healthcare activities going on in Maine, and got much of this started. So in terms of moving along, I want to introduce Jim Phelps, who is the executive director of the Iris Foundation. And Jim, do you want to say a few words of welcome?
Thank you very much. First of all, I do want to welcome all of you to the Iris Network. I'm sorry it's not a crisp June day like we had on Monday or Tuesday. Unfortunately, you know, this space is not air conditioned, and it's not. We don't usually have to contend with all the noise from our neighbor, the Portland School Department. They're apparently doing some summer renovations at the King Middle School next door. And they are also doing renovations on the Portland Ice Arena, which is our neighbor on to the west. So we're sort of surrounded by a construction site today, and it's made what would be just a warm day into a kind of warm and noisy day. So I apologize for the poor acoustics. The fans in here are also contributing to the noise, so we can try to balance that if people want less fan or more. You know, we'll do what we can to make sure everybody can hear, but a lot of that is outside our control. I do want to thank you all for being here. The Iris Network is very pleased to be working with the Maine Health Alliance, and we're really pleased to welcome all of you to the Iris Network this afternoon.
Thank you very much, Jim.
One housekeeping note, our finest restrooms are on the first floor. If you take the elevator to the first floor, there's a hallway perpendicular to the elevator, just a step to your left as you get off the elevator. And the ladies' room is first after a small closet, and the men's room is right beyond the ladies' room.
Thank you very much, Jim. Next, I want to thank our speakers, Kevin Lewis from the Maine Community Health Options, Lisa McPherson from Eastern Maine Medical Care, Deb Culver from Maine, the Health Infonet, and Ralph Johnson from Franklin Community Health Network. And we appreciate you being here today, and we look forward to all the wonderful information you're going to provide us. I think before we get started, one last, what I'd like to do is just kind of go around the table and just introduce yourselves to the group. and then we'll get started. And start over here.
I'm Aidan Marino from Eastern Seals, Maine.
David Searle from the Iris Network.
Bulletin from the Irish Network.
David Dunlop from the National Business Society. George Jubilee with the game breaker. Dr. Fred Lewis, CMO role of IT. John Baldacci.
Allen Brothers, National Alliance for Mental Illness and Maine. Lisa Hardy McPherson, East Maine Healthcare Systems.
Jessica Miller, Maine Association of Area Agencies.
Howard Hill, Maine Cancer Foundation.
Kevin Lewis, Maine Health Alliance.
Brett Johnson, Frank, anything up that one?
Thank you very much. And we'll get started now. Kevin, you want to get us started off?
And I think I'll go ahead and put my laptop up the power so we don't have a sentinel event. That in? There.
I'll try and project. If anyone has a hard time hearing me, please wave your hand or shout out, let me know. It's my pleasure to be with you here this morning. I'm anything but an expert in health information technology, but I am pleased to share with you some thoughts, and what I hope to be able to do is frame up some questions and tee up some subject matter that the true experts that follow me can work with, as I'm sure they'll be getting into some of these issues in their own presentations. And I would like to also build in some perspective in terms of how this crosses over into the payer side of the equation as we develop the first co-op in the state of Maine, a nonprofit health insurance issuer, to be functioning January 1st, 2014. So what I'll endeavor to do in the next few minutes is walk through some of the health economics, the landscape, if you will, here in the state very briefly, and then look at some of the success factors, the critical success factor that HIT really needs to play and can play in our state, particularly in rural parts. And then look at, as mentioned, the role for Maine Community Health Options, as well as other payers, in supporting and sustaining HIT advances. This probably isn't news to you in terms of healthcare consuming a greater chunk of our gross domestic product. That is measured by the amount we spend, what is paid to providers relative to the entire economy. So we've seen growth as a percentage of the overall economy as we've seen some of the sectors in the economy shrink, while healthcare has continued to grow. In Maine, that is an even larger slice than the national percentage, where according to the Maine Development Foundation in their measures of growth, 22.4% of Maine's GDP is occupied by healthcare spending. I think it's fair to say that it's a double-edged sword, that on the one hand, healthcare is a real engine for economic activity. On the other hand, it can be a real drag as we see the increasing costs into small businesses and businesses as well as individuals in terms of coverage taking a bigger chunk out of their budgets, whether business or personal. So what are some of the factors driving healthcare cost growth in Maine? These aren't an exhaustive list. This doesn't comprise an exhaustive list. But here are some that come to mind, I think, in any group. first, aging of our population. We are the oldest state in the nation as measured by our median age. And we have, as with the rest of the nation, increasing morbidity of our population, both in terms of chronic conditions and in terms of our overweight and obese population, which then compounds a lot of the chronic conditions or leads to some of the chronic conditions that then contribute to greater costs. Technology itself has been driving healthcare costs, whether it's diagnostics, advances in pharmacy, as well as new interventions, whether it's joint replacements or surgical advances. Now, one can also argue that on the flip side, these interventions provide a return, significant return by way of people's productivity and ability to contribute to the economy. But technology alone is often cited as a factor in driving the healthcare cost in Maine. The geographic spread of our population, coupled with the supply of new technologies, is itself a driver when we look at how do we sustain or how do we introduce and then maintain these technologies in some more rural community hospitals. It's an ongoing issue that I think needs to be addressed more fully as we try and figure out how we can best right-size the supply of healthcare in our state. And lastly, in terms of supply, physician shortage, and the maldistribution really of physicians across the state, both in terms of primary care and also in terms of location, rural versus urban. I bring these up because I think HIT can address each of these issues, particularly in the rural parts of our state. So whether it's connecting people at home with centers of excellence or centers of care in terms of the aging population, maintaining independence, and thereby having partnerships between providers, community resources, and people in their homes or in group living, certainly should play a factor in terms of the aging of our population. In terms of the greater morbidity, again, the biometrics and ability to tap into HIT solutions to allow people a chance and an opportunity to be able to live successfully with chronic conditions is vitally important. Technology itself can be aided by health information technology. And I think Deb will probably speak to this in terms of being able to tap into all the diagnostics that are going on so we don't have to duplicate tests and reduce the waste that may exist, as well as the exposure to additional diagnosis, repeated tests. And certainly pharmacy management and patient safety itself, pharmacy alone is a wonderful technology. Misapplied can be devastating, and so health information technology can level the playing field, particularly when we look at rural versus urban. Geographic spread, the example I would point to is what's been going on in New Mexico with Project Echo, where they've been pairing urban centers with rural providers to really increase the capacity of rural primary care to deal fully with a patient's complexity, as opposed to feeling the need to refer to specialists in the urban setting. A good example of this and where they started is really with hepatitis C care. Instead of clogging the urban centers with referrals, giving the rural providers greater confidence, really, because it amounted to more of a confidence issue than anything in terms of dealing with the complexities of hepatitis C. And then lastly, physician shortage. There's a good example that I heard up in northern Maine where a surgeon was recruited, and unfortunately it turned out not to be the best fit, and a large part of it seemed to be the fact that he was just coming out of residency and really put into a solo practice, if you will, within this northern setting, and having the ability to link closely, whether it's through Skype, whether it's through televideo, and really making sure that those connections exist, I think would advantage all of rural Maine. So I mentioned the measures of growth from the Maine Development Foundation. It's an excellent resource. It talks about a lot of different factors in our economy. They have a few that focus on healthcare. There are 2 red flags. One of them happens to be the healthcare costs in our state. And the benchmark that they are looking to achieve in just 3 short years is bringing down our healthcare costs to the U.S. average by 2015. That's about a 3 percentage point difference, at least on the conservative side. So how might we be able to accomplish that? We either have to shrink our healthcare costs in the state, or we have to grow the rest of the economy. And I am sort of philosophizing that perhaps the answer is both. That perhaps we need to both reduce the cost of payments for healthcare and grow the overall economy with the application of HIT. It's particularly important in our rural rim counties. If you look at where workforce has actually been diminishing with the recession. So healthcare workers in the state, we've seen a growth both in Cumberland County and in Penobscot County, and we've seen actually some declines in Washington County and Aroostook County. So how can we respond to that ably while still providing the services people need where they live? And it seems to come back again to what's the connection? How can we establish those connections that I'm sure that Lisa and Ralph will be talking about, and Deb is creating the infrastructure in Health InfoNet to help support it all. So then I also want to introduce the concept of applying HIT specifically to achieve the triple aim. And the triple aim is something that was born of the Institute for Healthcare Improvement. Don Berwick brought it to the Centers for Medicare and Medicaid Services when he was leading that agency. And it's an ongoing legacy I hope that our nation will hold on to in terms of our government's focus on the triple aim. And the 3 parts, we normally think of 3 parts being cost, quality, and access. In this case, they bundle both. They bundle it a little bit differently. So it's reducing the per capita cost of healthcare, improving the patient experience of care, which gets to the quality and satisfaction aspects, and then improving the health of the population, and that's where you find access in that equation. In terms of reducing the per capita cost of healthcare, I think HIT has a tremendous amount to contribute. As we've already seen examples that I hope we'll be able to explore some more this morning and afternoon, in terms of pharmacy management, in terms of home monitoring, in terms of the consultative model I mentioned between specialists and primary care providers, and in terms of engaging in behavioral health integration with the backstop or the help of telepsychiatry. Sweetser has put in a connection to Indian Township in Princeton. And if we can provide telepsych in Princeton, Maine, with a T1 line that is using old copper, so it's a 1.5 meg connection, we can pretty much do it anywhere in the state, I would venture to guess. And looking at patient experience of care, HIT has a lot to do with the accessibility of data and using that data to support decisions being made by clinicians and ultimately decisions being made by consumers in concert with their care teams, and that whole focus around shared decision making. And driving more of that to where the consumers, where patients want to capture the information, perhaps in the comfort of their own home, through secure portals, and so forth. And then last, improving the health of the population. utilizing data to trigger interventions and then measure interventions on entire groups. And then with that information, refining our predictive modeling so that we're able to focus our resources where they're needed, where they have essentially the biggest return on that investment. So conditions for success. I think a lot of us, certainly I, when I think of HIT, I immediately think of EHR pretty quickly. Fortunately, we see that the rural has caught up with the urban. It's certainly the case of federally qualified health centers, where I most recently, that's where my experience base in the state largely lies. However, I would put that meaningful use has really yet to be determined. So we have some good energy around meaningful use in terms of, as this next bullet indicates, the regional extension center that's at Maine Health Infonet, and the incentive payments that came in via Maine Care and Medicare through the High Tech Act have all really catapulted awareness and a desire on the part of the provider community to take electronic medical record systems beyond simply electronifying paper records and making the most of the information for the benefit of patient care. The other piece on capital is that there's, I think we're seeing more and more approaches that are less hardware intensive. So whether it's the state EHR vendors themselves that are offering solutions out of the cloud or ASP models, which is sort of a remote application service provider, so that big servers don't have to sit underneath desks or in closets and have to be maintained and upgraded, and that the actual EMR product itself doesn't have to be continually upgraded.
Through all of the kinks that happens with each one of the upgrades, but rather that happens on a subscription basis elsewhere. And Athena Health is, I think, the one that really has pushed the envelope, and certainly in this state, and I think made other vendors pay attention and move a bit more quickly. So they deserve, I think, a lot of credit for that. But the more that we can, as long as it's reliable, and as long as it's, there's redundancy and it's safe and secure, the more that we can rely on that kind of cloud technology and get it out of the provider walls of the provider space and allow providers to focus on what they do best, and supported by the data, the better. And lastly, it's the infrastructure and the bandwidth needs. We've seen Maine come a far way, and really, I think a lot of credit goes to Governor Baldacci for all the focus and effort in terms of the bandwidth needs of the state. And still, I think we need to pay attention to it. Even despite my comments about Princeton, we can certainly do a lot with a T1 line. But as we see technology continue to evolve, we're going to have to stay on top of this infrastructure, just as we have to stay on top of the infrastructure of the roads. And I think this current administration needs to pay attention to the bonding and investments in R&D and investments in IT infrastructure, just as they need to pay more attention to our roads themselves. And then lastly, we have capital, we have infrastructure, and I would say culture is the last one. And I put we have Silicon Valley. Well, we could have Silicon Coast. Thinking about the great place that we have here in the state of Maine and all of its attraction, we certainly, I think, could attract the kind of creative economy that's vital for us to continue to make the leaps we need in the area of HIT applications. I probably have run out of time.
Just about, not quite.
Okay, so I'll just quickly go over in terms of Maine community health options. what that is, because some of the same arguments I've made in terms of application of HIT to healthcare to reduce costs and increase the value applies to the underlying mission and how it is that we came to create Maine Community Health Options. Under the auspices of the opportunity was there with the Affordable Care Act in terms of financing co-ops, a consumer operating oriented plan that's nonprofit and designed to bring as much value to the subscribers as possible. So the attributes of the plan, in addition to being nonprofit, that it has to be consumer driven. Directors of the board are all elected by the subscribers, and it can't be converted. So at the very least, this is a return to having a nonprofit plan domiciled in Maine. But more than that, we want to be able to integrate care, foster payment incentives to improve efficiency and quality, and sustain the solvency of the plan, but also the solvency of Maine businesses, and really help to separate the linkage between health insurance and employment, if that's what the market is demanding in terms of supporting some of the creative industry that Maine is known for. And we aim to use HIT both within our own administrative structure to drop our costs, because we want to have one of the leanest plans out there. It's the only way we can compete. I mean, we're up against some pretty heavy hitters, as well as be able to apply it very effectively for our subscribers so that they can access information, their own information, and use whether it's mobile apps or the web portal, again, to help connect them in ways that are most meaningful to whether it's medical care, to peer supports, to what they regard as wellness. So I will not go through all of the co-op except I would just point to this last piece, and this is not all inclusive or exhaustive, but in terms of partnerships for success, we really see the need to work closely with the provider community. I come out of the provider community, the primary care community, so I certainly bring that with me in partnering with the safety net in particular, but also the agencies around this table and agencies throughout Maine that are promoting public and population health and community resources that are oftentimes not fully recognized for the power that they have in affecting and benefiting people's lives. And through this, we want to strengthen community-based public health and prevention, align our policies and practices to support primary care and prevention, and reduce inefficient practices and waste, and work collaboratively towards payment reform. So it's been a pleasure to put some of these ideas and thoughts on the table, and I'll gladly turn it over to Earl. Okay.
Kevin, thank you very much. Thank you for doing a great job of setting the stage of health technology issues here in Maine, as well as all the great work that you're doing with community health here in Maine. And today is just the beginning of a dialogue, and we hope and expect that this process will continue going forward. So thank you again. Lisa? Lisa's going to talk about all the great things that she's doing at Eastern Maine Healthcare, and particularly around home health care and the use of technology. So
yes. Okay, thank you for the invitation. It is so exciting when I have the opportunity to talk about home care telehealth. As a general rule, when we're invited to speak, we're talking a lot about electronic health records. We're talking about how we can interconnect and interface hospital EMRs with physician EMRs. Very rarely do we have a forum such as this where we can highlight home care telehealth. So I'll start with Some background on Eastern Maine Healthcare System. I'll do my commercials. So we'll have a little commercial about EMHS and Eastern Maine Home Care, and then I'll talk mostly about home care telehealth. So the mission of EMHS is to maintain and improve the health and well-being of the people of Maine through a well-organized network of local healthcare providers who offer high-quality, cost-effective services to their communities. We serve 2/3 of Maine's geography, and we have a strong culture of health information technology. And if you think about where EMMC sits as a tertiary hub, 13 of the state's 16 critical access hospitals are in our service region. So we have a responsibility for a very challenging part of Maine's population to make sure that we have the right balance of access at the local level and access to the technology that we have and the physicians we have at Eastern Maine Medical Center. So to be able to meet the needs of this region, we have invested in a strong network of technology, telepsychiatry, tele-ICU, teletrauma, telepediatrics, and in home care, we've done telehealth for more than 10 years. So for Eastern Maine Home Care, we have the visiting nurses of Aroostook, and we have a branch in Caribou and Houlton and a drop site in Fort Kent. The drop site is just a location where we keep supplies, and the staff can go in and have access to phones and faxes and laptops if they need them. Hancock County Home Care and Hospice, we have branches in Blue Hill and Bar Harbor. And Bangor area visiting nurses, we have our branch in Bangor, and we actually serve down to the Waterville area, so we have a drop site in Fairfield. But this is the territory that we serve. So if you think about visiting nurses of Aroostook alone, we cover 6,000 square miles with 2 branch locations and a drop site. If you think about the Hancock County region, our staff travel to the islands. Now that's not a bad job, but it certainly is not a way to efficiently deploy staff at times. And then we have this challenging central region with an urban hub. People ask me all the time, why did you set up Eastern Maine Home Care's territory like this? Why did you omit this region in the middle? And as Eastern Maine Home Care was formed, we were really formed as hospitals came into our health systems, they brought their home care programs, and community health and counseling serves this center swath. And particularly when I talk about Beacon, we have a strong partnership with community health and counseling, and we work very, very closely with them. But that's how we ended up with this kind of funky geography. So last year, our staff drove 1.25 million miles, making 64,000 home visits to over 3,300 patients. So over 10 years ago, we began using telehealth. We've been doing this for a long time. And a lot of people think when I talk about telehealth, they think I'm talking about the video connection. And we used to do that. And we actually got rid of that technology. We had problems with the bandwidth in the rural communities. And believe it or not, for home care, that visual video technology was not an efficient way to conduct a telehealth service. So the program we have now and the analytics that we have now are far more effective, and we don't exactly see the patient. So the basics, here's the telehealth nurse. So our telehealth nurse is Kim, and Kim's in Caribou. So we have one telehealth office serving all of Eastern Maine Home Care, and one FTE telehealth nurse can manage a census of 200 telehealth patients. So you see that Kim is at her desk. This isn't Kim, but you know. So Kim's at her desk, and it's web-based technology. So every patient has one telehealth encounter a day, and we begin our day with the patients who are in the red flag, that they're at the highest risk, and I'll show you how we know that. We handle most of our changes over the phone, or we may deploy a nurse, or on occasion we dial 911. Now the cost difference between an in-home visit, deploying a nurse into the home, versus a telehealth encounter is $120. Now for Medicare, we are paid an episodic payment covering 60 days of care. We continually discuss, can we continue to serve this very large geography, particularly in Aroostook County, particularly with a lot of seniors. How can we continue to do this? And telehealth is a way that we are able to achieve the right balance of deploying staff into the home strategically, because we know every day what's going on with this cohort of patients. So every day, here's the patient, here's the equipment that they have in their home. So every day, they upload data to Kim and Caribou, and we know their blood pressure, their weight, their blood sugar, their pulse, their O2 sat, and they answer a series of individualized questions. So I'm going to talk about, you'll see slides about the dramatic impact that we've had on reducing ER utilization and rehospitalization rates. But if you think about it, and you think about patient engagement, every single day, on average, a 60-day episode of telehealth, every single day, the patient is engaged in their care and reporting data. So if I think about, if I were part of this program, I had this fantasy. I have this fantasy, I'm on a diet, you know, kind of watching my weight. If I had to tell Kim every day what I weighed, well, I'd be a little bit thinner now, wouldn't I? So you can see that most patients, I get a doctor this week, I guess I'll, be good. They're good each and every day. And we have a good compliance rate because we have risk corridors where we know that the patient is in a red flag arena, that they're outside of their parameters, and when Kim is calling them, or we're deploying a nurse. So they're very engaged and very accountable. So here's how we start our day. Every day, we can tell who's at risk for readmission, who's not taking their meds correctly, who's depressed, who's not following their diet, and who's having trouble with their activities of daily living. So I'll tell you about two patient stories. And I went and I worked with Kim because I'm a nurse and I wanted to really see how this program works. So I go to work in Caribou and we begin our day. Who's at risk for readmission? Who might be going to the emergency room? And we have a man, and he's an older man, and prior to coming on telehealth, he had been hospitalized 6 times in a 12-month period with congestive heart failure. He flags he's at risk for readmission. And we have a trend line. His weight is going up, his pulse is going up, his blood pressure is creeping up. He's reporting that he's short of breath, he's sleeping on more pillows at night, and his ankles are swollen. So I call him right up, and I say, "Hi, my name's Lisa. I'm your telehealth nurse today, and I'm concerned about some of the data that we're seeing, and I'm concerned about how you're doing. And I see that your blood pressure is going up, and you're more short of breath, and you're gaining some weight. Tough old man." "Oh, I'm okay, dear. Don't you worry about me." He says, "You go right ahead and you go take care of some sick people. Don't you worry about me." And so I talked to him a little bit more, and he says, "Oh my, is this when I'm supposed to take 2 of my water pills? The doctor told me to take 2 of my water pills when this happens." And I said, "Well, why don't we do this? I'm going to send a nurse up to see you today, and we'll have the nurse check you over, talk with your doctor, and we'll see if that's what he wants you to do today." That's in fact what we did that day. That patient was never hospitalized again, never went to the ER again. Once he was on this program, and he was on it for an extended period, but he began to self-identify his behaviors, his triggers, what was contributing to his frequent hospitalization rates, and we effectively intervened. But it's as much about keeping them out of the hospital as it is sending patients to the hospital when they need to go. And so Kim has a patient, and we know this patient very well. It's an older female. And we begin to see she's in our risk corridor. So we call her. Kim calls her. And she has an altered speech pattern, and she's slightly confused, and she lives alone. She's having a stroke. So we tell her that we're going to dial 911. We're going to give her daughter a call who lives distant from where the patient is, and send her to the hospital. And that's indeed what we did. And she was hospitalized for 3 days and returned back home with minimal impact from that stroke because of the early intervention. Prior to this service, this is an individual living alone in a very rural, isolated community. She either would have died or had a very extended hospital stay with a post-acute nursing facility stay. And we can also manage patient flags. So not everyone's at risk of going to the emergency room, but we have patient flags that tell us there's something going on with this patient. They're outside of the parameters that the doctor has set. And so sometimes it's as simple as the patient's weight is going up and the blood pressure is going up, and we give them a call, and you know what they say? I had Coaltion last night. Do you think I should have done that? And we say, well, no. And so they're very actively engaged. And we can also have a sense of what are people's patterns, because we have another gentleman that even with telehealth, he was still going to ER, and we were trying to figure out what was going on, and when we looked at his pattern, he would have a weight gain of 1 to 2 pounds a day, and then he would rapidly retain fluid, and into the ER he went. So for that patient, just a slight uptick in his weight was our trigger to understand that I had to get a nurse out there, or I had to get him in to see the physician, because he would rapidly build up fluid. Now, we have, it's a web-based program, so we can provide access to this to the physician practices. And as a general rule, it's the care managers and the patient-centered medical homes that go in and will access this data. So for the vast majority of the patients we have, we track their physician visits. In advance of their physician visit, we provide that primary care provider with the patient trending information, so the primary care provider understands what has been going on with that patient since their last visit. And here are the questions. And so in addition to the clinical data, they may not be falling out into the risk corridors, but they may not fundamentally understand how to take their medications. And for whatever reason lately, med management, med reconciliation has been highly problematic, and that has been a primary reason why, particularly for the community care team, which is another program we're developing, that we've got patients in and out of the ER, and they're not managing their meds well. And so for this question, over the past 7 days, how would you say you've done taking your medicine as prescribed? Would you say you've taken it all exactly as prescribed, you missed a few pills, or you've missed several pills? And how we use this data is the home health nurse that's going into the home understands what is my teaching focus for this patient during this visit. Is it their diet? Is it their med compliance? Is it assisting them with their ADLs? Do I need to get OT or therapy involved? Strategically thinking about how do we deploy our staff and how they are highly impactful when they're providing that home health service. And so the survey questions, are symptoms like the gentleman who had a lot of CHF. Are you more short of breath? Do you have any new edema? And that very often will change the text. Are your ankles swelling? Have you taken your medication? We do education surveys, so we'll assess their knowledge base around heart failure, hypertension, diabetes, asthma, COPD. We ask them about smoking, diet, lifestyle. Do they understand the signs and symptoms, what it means to go into congestive heart failure, and how they're doing with med management? And then we have teaching surveys, and we actually quiz them and score them on their knowledge. And then we do risk stratification around readmission to the hospital. We do risk stratification around Wells assessment. And you can't really see it, but we also do risk stratification around how they're managing their wounds. So when we took a look at this, now we've been doing this for 10 years. There's no third-party payer coverage for this. We started doing it as a way to effectively manage the cost of providing home care. And from the inception of when we started 10 years ago to today, we've received cumulatively $1 million for this telehealth service. And so a few years ago, I began to think about how can I take a look at this program in a different way, in a way that would be of interest to funders. And so I began to take a look at what's the impact on the cost of health care and inappropriate utilization of health care when a patient has telehealth home care. So what we looked at is we compare one 60-day episode of home care with telehealth to the cost of a hospital readmission. And the savings are the net difference. And it's based on the cost of our health system. So these are Maine patients, Eastern Maine Healthcare System hospitals, and you can see when we substitute home care for one readmission, we have a dramatic impact on reducing the overall cost of care. Great, perfect, I'm just about done. And then we looked at, well, what's happening with ER utilization and rehospitalization rates. You can see 6 months prior to going on telehealth, 80%, 50 to 80% in and out of the ER, in and out of the hospital. It goes down to 0 to 14% because we effectively deploy services into the home to intervene. So a little bit about Beacon. I know Dev might talk a little bit more about Beacon. We're honored to be one of 17 Beacon communities, and the premise is how can we leverage health information technology to improve health outcomes and reduce the overall cost of care. And I'm going to talk about a teeny slice of Beacon, that's home care. Beacon is a significant project, all-inclusive in Bangor. And you can see the participants, and those highlighted in pink are the home care partners. And the Beacon telehealth program serves homebound and non-homebound patients. And they simply have to have one of the chronic diseases, asthma, diabetes, COPD, or heart disease. And we benchmark our progress in similar to what we know in home care, reducing ED visits, readmissions, improving patient self-management, and then generally increasing the use of our services. So here's Gerald. So Gerald's a typical Beacon telehealth story, in and out of the hospital. In the summer of 2011, he got worse. He was in the hospital a couple of days every month. We admit him to our telehealth Beacon project, and he successfully now manages his chronic diseases. He can spot his warning signs, and he says, I'm thankful for this program. I know it's kept me out of the hospital. I hope to be soon to get my energy back so that I can get on stage again. He's a drama teacher. And thank you. Pretty close to being on time.
That was excellent, Lisa, and you know it's great to see.
My labradoodles. When all else fails, you can say she's got great looking dogs.
An extra treat.
An extra treat. Yep.
Thank you very much.
And Deb, are you going to hook up your laptop, or do you want a thumb drive?
And while Deb's doing that, we've got about
like he's gonna hook
5 to 10 minutes if folks want to take a break.
I just also want to say that
I'm going to talk a little bit about Health InfoNet, but I'm really more interested in a slightly elevated level, and so I'm going to spend more time on other topics, and I'll come back to Health InfoNet, wrap it in as part of the discussion. But as a fairly seasoned individual who's been around health technology for a while, I always am uncomfortable when we start to build entire strategies and visions around technology. And so I wanted to start here with some concepts of change that I think are really important as we look at how we can do better in Maine in terms of coordinating care both within the rural environment but across the state as a whole. And I'd like to propose three areas, three definitions or thoughts around change that I think are really relevant to both today's discussion but also, quite frankly, in your thinking about where we go. The first one has to do with the fact that technology by itself is not admirable. As a goal in and of itself, it's really what we should not be trying to do. It really should be in the context of technology that's disruptive, which supports a defined incentive or direction. Those two together make a difference. They create change that actually has a benefit and has outcome. Either by themselves, without the other, is actually not productive and gets in the way of things. And you can think of many situations where we've had really cool technology, but it hasn't done a darn thing. Or we've had some really good incentives, but the technologies weren't aligned with them and things didn't happen. So I think as we look at these questions of what we're doing with health technology, I really like where Lisa was going, because that really brought together the concepts of the technology and the incentive. The fact that you can cause a patient to change their behavior. Increasingly, you're seeing a lot of these types of programs, and I'll talk about something else in a minute, but a lot of these types of programs where the technology is the underlier to keep the patient focused. And I think that's a really terrific direction. Secondly, there is no old problem that can't be solved with technology by creating new problems. I mean, technology by itself solves problems, but frequently creates as many new problems as it solves with old problems. So you have to be very, very careful in assuming that you're going to solve an old problem. You may solve it, but you invariably will create a new problem. And so part of the challenge of looking at what we're doing here for concepts of connection is to understand and be comfortable with the idea that you do things with technology and new surprises appear. Sometimes they are really good, sometimes they're really bad. But you have to take that into account as you're starting to think about what we're trying to do with actually causing reform to happen. And finally, for those of us who've been on both sides of this equation, change is always fun as long as you're doing it to someone else. And I think if you look at the process we're going through today with the adoption of EMRs, the folks who are going through that process aren't having a great time. Trust me. It is extremely disruptive, it is extremely challenging, and they're having a hard time seeing past the obvious, this isn't the way it used to be. My wife's a psychiatrist down in Providence, and she comes home on a regular basis and tells me all about her primary care physicians who are going crazy because they're going home at night after work and spending 5 hours catching up on their electronic medical records because they can't get them done when they're in the office. Now, that's not necessarily positive change, if you think about it, but the fact is, quite frankly, they're being moved through a process right now, and it's being done to them, and that's part of the challenge, is getting through that and starting to see the benefit. But I think if we can sort of wrap this concept around what I'm going to talk about and then try to put these into pieces when we look at what I'm going to bring forward here, I think it'll help with the discussion. Likewise, when Kevin was doing trends, I think there's some very key things going on from a technology basis that this group needs to start thinking about in their thoughts of how we change things and improve care. First and foremost, mobile computing is becoming a standard of practice. Everybody, mine's next to my board member down there, but everybody is carrying a phone increasingly. There are fewer and fewer people who don't have not just mobile connection, but smart connection. And even those folks in most rural areas, number three being the point, increasingly connection is ubiquitous. It's there. It may not be terrifically fast, but it's there. And so these begin to have implications, particularly when we talk about that very large challenge of the patient or the consumer. Engagement of that particular group has been the hardest part of reform. Anyone in this room who's gotten engaged in trying to change consumers and have them participate in this little revolution we're in the middle of understands how hard it is to engage in a process that by its very nature is complicated and confusing. What many of us do for a living is so opaque to what the consumer runs into on a daily basis. But I'll tell you what, between mobile computing and social networking, that opaqueness is going away, and it's going toward a very different direction. And the question we have to ask ourselves as we're looking at how can we do better, both in the rural setting and the urban settings, how do we harness these forces? They're here. They're going to drive us like crazy. They're going to go places. Remember, sometimes technology takes you places you don't want to go. They're going to take us to places that don't make us too happy, but at the same time, they are infinitely powerful in terms of creating some opportunity for, I guess, what I would call continuous engagement. You know, the fact when Lisa talks about that daily reporting thing, that's a little bit of that reinforcement on a daily basis. This is 24/7, and sometimes can become a disease in its own right. But the fact of the matter is, how do we increasingly use this concept both to reinforce and encourage folks forward in terms of their health and health care? I will tell you, the social network component of this is incredibly powerful. There have been some really neat work done. The VA's been working on a weight management program for folks with cardiac issues for a number of years now. And what they discovered in the last 2 years is when you bring these guys, and they're mostly guys, you bring these guys together inside of a social network concept, you present their individual goals and they start competing. And they also start encouraging each other. And guess what? Their weight loss is significantly enhanced because now they're in an environment where each is talking to the other one about how they're doing. Now, every once in a while, somebody puts the pedometer on the dog. That's one of those unintended outcomes. But the fact of the matter is that concept of a shared group working toward individual goals is extremely powerful. And I think as we start to look at chronic condition management, as we start to look at the question of how do you help support people who are perhaps distanced a little by geography, this type of a concept, done right, done well, done in a controlled and directed manner, becomes extremely powerful. I've talked about broadband and Wi-Fi. Again, I understand there's a difference between the pure rural environment and the urban environment, but what I am struck by is even, and I've lived in Maine, in and out of Maine for the last 23 years, I'm struck by how that barrier is falling down. It's coming down, and now increasingly it's not that you can't find signal. You can find places where you can't find it, I guarantee you, but it's getting to be narrow and narrower, and so that begins to introduce the concept of if you can take the first two and the third comes along, what can you do to impact care, literally. The fourth item up there, I think, is one that is one of those good news, bad news things. I'm in the business of aggregating data. That's what I do. I bring in clinical data, I organize it around the patient, and then I present it back out to the provider at the time of service to create as much of a comprehensive view that incorporates how different providers see that patient. That data in itself is as powerful a tool for change as the actual event of presenting it to the provider at the time of care. And with it comes a whole bunch of concerns and issues that are very legitimate about privacy, about security. But I'm going to tell you right now, and you're going to see it all over the place in the headlines and all the rags that are out there, the term big data. I kind of had this 1980s thing with hair going on here. But big data and the concepts of the value of big data at doing significant change or direction change in healthcare is fundamental. And over the next 2 to 5 years, you will begin to see some significantly important work coming out at a population level that will radically change how we look at what we do and why we do what we do. You know, that whole concept, we talk about evidence-based medicine, right? Well, the disturbing thing is only about 10% of medicine is truly evidence-based. The rest of it is community-based, which is, this is the thing we do in the community that seems to get the best outcome. What this type of thing does, what this big data thing does, is it begins to drive the question of what really works. What really happens on a large scale, large quantity comparison of disease types, disease treatments, et cetera. So increasingly, while we must acknowledge and manage this for the purposes of not violating people's privacy, it becomes an incredibly important tool for doing better. And quite frankly, what we're going to see is we're going to start to see that become the foundation for planning for health services, investment, et cetera, because you're going to begin to see on a much more longitudinal basis the impact of an event driving change. So,
stop for 1 second, the microphone.
Oh, the microphone went off.
Replace the batteries real quick.
Okay.
Continue. And
anybody got a good joke? Now, actually, you died at just the best time. What? The music keynote? What? Think about this. Anybody in this room who's Pandora? Okay. Very, very interesting what's going on underneath that beast. What it's doing is it's taken and it's broken apart music into categories and subcategories, and then it's allowing you to shape what you like. It's exposing you to a set of structure to sort of shape your pleasure, right? Take the previous question of big data, and then you add to it the concepts of ways to expose myself where I don't expose my identity, but I expose what I'm looking for and allow me to score what I get back. Isn't that what we do when we do with Pandora? Think about what that does to the concepts of transparency and healthcare selection. So now increasingly, I can go find, this is going to sound bizarre, I can go find retail services. Well, is a doctor a retail service? Yeah. Is a hospital a retail service? Yeah, sort of. But I can begin to expose what I either need or want to a data set that allows me to do what I do best as a consumer, and that is make informed decision in a transparent manner. So I can actually bring together and look at the concepts of outcome measurement, cost, distance. Interesting. And start to make some decisions about where I might want to go for services based on that. And that's this whole concept of the genome. I'm now able to start to dissect the opportunity against something that I want. And I think over the next 5 to 10 years, that's going to be incredibly powerful, both as a driver to do better, but also it's going to be incredibly disruptive in the provider community. Because today in the provider community, it's very opaque. And so for making decisions, informed decisions based on things that consumers do understand, I think we're going to go well past the concept of, oh, it has really good food. That's how I select my hospital. So I think pay attention to this one, because this one is really going to be an interesting way to start really doing informed decision making. I think there are also some key drivers. Remember, now that's the technology side. You know, that technology can easily run amok by itself, and it will. But the fact of the matter is now you've got to have the incentive side. What drives that to cause, I'll say, positive change, but what I'm really talking about is disruption. And when I talk about disruption, that's not a negative term. That's a positive term. That's meaning we're causing something to change because there's an advantage to do it better. You can interpret, if you're on the, I suppose if you're on the losing side of the disruption, you can interpret it as a bad thing. But the fact of the matter is that creative destruction thing is actually quite important to how we're going to move our healthcare system along from what it has been to what it needs to be going forward. So again, I think the concept there of basic disruption is a good thing. So I think there are some very important things happening. Many of you know these things. I'm not telling you something you didn't know, but what I'd like you to do is step back and in the concept of the disruptive technology, now start to look at the incentive that's behind these. Clearly, the patient-centered medical home is like an old idea coming home to roost, but it's coming home to roost now. Instead of one person being the centered home around the patient, it's now a team of people, you know? The only way that team is going to work is if there's a technology infrastructure that allows them to work as a unit. You know? That's the only way it's going to work. And quite frankly, what I'm really starting to enjoy in this whole initiative is important components of that community are starting to come on the table. When in our wildest dreams would we have ever thought that the pharmacist standing at the pharmacy bench would become part of the actual care team, not the pill pusher, the actual care team? What you're going to see over this next 2 to 3 years as accountable care and others start to drive the question of management is some very key players who have not traditionally been thought of as being part of the care team are going to now become part of the care team. And you're going to see a pharmacist directly engaged in understanding what's going on with you medically, actually seeing that information, looking at the pharmacy profile that you're carrying around with you, and going back to the team members and saying, hey, you could do better if you did X, Y, and Z. And the impact of that's going to be much like what we saw in hospitals in the inpatient setting back in the mid-90s when, oh my gosh, we started to take PharmDs on rounds in the intensive care units. Guess what happened? We started to do better. So I think you're going to start to see this. The only way that model is going to work, though, is if the connectivity is there and the tools are there that allow each of those disciplines to see that person in a way that's meaningful to them, but to be able to see the person as a whole across that team. So over the next 2 to 5 years, those basic, very basic building blocks we've got right now, like secure messaging, like the EMR, will become fundamentally more sophisticated and will be focused on how to manage that team across a large geography to get an impact that's better. So I think that's it's a wonderful concept. Yet it's so old-fashioned. It's just we've now walked away from the concept of a single provider being the patient-centered home, and now we're building a team. Accountable care is, whether the Supreme Court blows it up or not, forget that. Everybody in this room knows we got to change. That we cannot continue as we are in our structure. And I would argue that most of the folks involved in organizations that are delivering care today understand fundamentally that they're going to increasingly have to assume roles of managing risk. That that's going to become part of the reward structure. And again, this is where the technology that's disruptive collides and then begins to support the change in incentive. We're suddenly starting to look at the question of projecting risk. Now, that could be either a really bad thing or a really good thing. You know, in the bad old days, you would assume that's what an insurance company did to avoid covering lives. Now, increasingly, it's going to become a question of what a provider does in order to focus their resources most effectively to deal with those individuals who are the highest risk in terms of potential outcome, even 2 to 5 years out. So that is really going to be what's going to be fun to watch here. The incentive now is going to pay me to make sure that that person never gets to that bad outcome 5 years out, or 8 years out, or 10 years out. And the models, the tools that are starting to be developed here today are primarily claims-based. Those are going to modify and grow as the clinical content becomes much richer and becomes much more standardized for using. You're going to see a much more significant blending of these tools, and they will be used, I hope, for the right thing, which is let me find and figure out someone who's starting to show signs of going somewhere where we're going to have some serious cost and personal issues at a point in time out, and begin to manage them, help them manage themselves so that they, in fact, reduce the probability of that impact. And again, I think that's a wonderful, exciting thing, and while it scares the hell out of the provider community today because they've never had to go there, I think increasingly it forces you to address the concept of the whole person. Now, I know of at least one person sitting in this room who's been a valiant champion for that concept, because she works very hard on a group of folks who always want to be isolated because they want the head treated differently than the body. What this starts to do is it starts to call the question. Why would you want to treat the head separate from the body? because at the end of the day, you're going at risk for the whole. And I think that's really positive. So that big data thing, driving some tools now with the incentive being manage that person to optimize their potential to avoid bad outcome, I think becomes a really attractive and exciting thing. I throw high tech up there not because I want to go backwards in time, but I do think fundamentally, even if the Accountable Care Act gets blown up, whether they intended this or not, by bringing a high tech law in 2009, the Obama administration actually put into place the fundamental machinery to measure. That's really what this whole darn thing is about initially. And all this stuff about EMRs and meaningful use and yada, yada, yada. Yeah, it's very important. It's very distracting too, by the way. It's very important, but at the end of the day, fundamentally what's being put in place is the machinery to be able to measure so that you can tell when you're actually doing better. That's what's underneath this whole thing. So again, even if ACA blows up, hopefully the incentives don't get perverted, because that's what sometimes happens here. The fundamental machinery is in place, the incentives are in place to start to be able to do things with that data to demonstrate and to project what's going to happen and what you can do better. So it really, again, I don't know fundamentally whether they chose to separate them on purpose. I mean, what the heck is that? Is it a stimulus plan? That's crazy. But it isn't. It's a very smart plan. So we'll start to see how that plays out. And again, ACA comes, goes, maybe. As long as the incentives don't get totally perverse, happens sometimes, then basically we've really gotten in place already a substantial step forward that will begin to be optimized over 5 to 10 years. So I think we should be very excited about that, quite frankly. Then, as my segue into Health Infonet, yes, health information exchange in its own right is a disruptive concept. And it's disruptive because it challenges a number of assumptions that we have in place today. It is basically and fundamentally a concept that the patient's data is not owned by anybody. That it really is the patient's data, and the objective is to make it available to everybody who's treating the patient. And you know, Ralph and I are, Ralph's a current CIO, I'm a recovering CIO. Back in the bad old days of the 80s and early 90s, the idea was that if I could only just get my system on your desk as a provider, I would own you. You know, it was so easy for you to work with me, you wouldn't put your patients anywhere else. I've got to tell you, that's baloney. It doesn't work. But the fact of the matter, Maine has been very successful in this area. Maine was starting to do health information exchange before the federal government had ever gotten it on their site to get it as part of legislation. And Maine made two very fundamental decisions in 2005, which I think we're starting to see the dividends from today. First decision, the provider community decided to integrate its clinical data into a single data set. Now think about that. What we've got, if you go around the state, is all these lovely silos. And they see you as a patient within the context of that silo, but I'm sorry, you move across silos on a regular basis. So we don't really see the patient. That's a fundamental trust decision, to integrate your data into a single data set. But the real trust decision was to come to the point to say, we're not going to compete on patient data anymore. The patient data is going to come ubiquitous to the experience. You remember my ubiquitous networks? Patient data becomes ubiquitous to the experience of supporting the patient in care. So it isn't that I got the data and you don't, it's that I really want you to have the data because that's part of fundamental trust.
And I think that have really been at the foundation, and again, Ralph and others in the room have been at this actually long to have, is really fundamental why we are where we are today. And so sort of take that as a takeaway, but it is disruptive. It causes political challenge. It causes, you know, I wake up every once in a while and someone's beating me over the head asking me why I'm misusing their information. I don't mean that from a patient perspective. I mean that from a provider perspective. You know, how dare you give that information to another provider? That happens now and then. And we have to sort of reset the table and get the concepts of the trust framework back on the table so that they understand that it actually is of value to them to have that information being shared elsewhere. So let me tell you about Health Infonet. For those of you who don't know who we are a not-for-profit that was formed in 2006 after a 2-year effort that was looking at whether or not Maine was ready for a health information exchange. Understand, that's such a nascent idea. The concept of a health information exchange was so nascent in 2004. And now it's suddenly, you know, what did we blow?
$560 million in the High-Tech Act was specific to health exchanges. But the fact is that most of those exchanges still are not operational. Most of them still aren't living the dream. I'm not sure I'm living the dream yet either, by the way, but the fact is that they have not even gotten to the first step of showing their potential, whereas I would argue here in Maine, we're at that first step at least, maybe the second step. We basically have been involved in two very important projects. One is the exchange itself, and I'll go through some highlights of that in a minute. But the other one has really been engaging in two really great projects. One is helping primary care docs, primarily primary care docs who are serving underserved populations. That's by definition of what the Regional Extension Center is. To get through that very ugly, painful process of getting an electronic record installed, getting it part of the daily apparatus of the practice, and because we love what we do too, in Maine's case, connecting them to the exchange. Now that's not a requirement of the federal money. We decided since we are the exchange and we're also doing the rec, what the hell, take advantage of it and make that a requirement of being in the Regional Extension Center program. So we have 1,000 primary care physicians in the state of Maine who are primarily serving underserved populations, who are under contract to be connected to the exchange with their EMR before 18 months get done now. So it's a 4-year effort. That's really phenomenal. Think about that. That's 1,000 providers who will be physically connected into the structure and hopefully using it to the best to serve those folks. The Beacon project, again, Lisa mentioned this, but I got to tell you, Maine has shown itself in a way that I think is really both a credit to Maine and, quite frankly, a credit to the greater Bangor community. There are 17 Beacon initiatives across the country. The fundamental concept is demonstrate what happens across a community when you have a high level of penetration of information systems that can talk to each other. That's at the basis. What it's really all about, though, is measuring impact. Remember I said that's what high-tech was about? It's really all about showing what happens when you have a coordinated community in terms of the 4 basic chronic conditions as far as outcome goes. That's what the Beacon's all about. So you have this wonderful situation where prior competitors are actually sitting around the table talking about standards of practice that are common and then going out, implementing and measuring the impact across the community. That's really terrific. And by the way, they are, when you look at the impact and the outcome of the 17 so far, this particular project is like at the front of the pack. They are actually demonstrating measured impact. And that's cool. I happen to like being underneath it all. That's kind of fun too. But the fact is that it is a wonderful test bed, and I'm going to talk about some of the opportunities here. It's also a wonderful model for us to be looking at for the rest of the state as we start to move into this next generation of trying to connect. Because we've learned a heck of a lot in this project and can take that, I think, and make it part of a rural connection objective, make it part of a community-to-community connection objective. So it's just some really good stuff happening there. So that's got to be mindful of the timer. So basically, we're Maine-based. We're not-for-profit. In the room today, I have 3 people who actually participate. One's a board member, and you can raise your hand and say hi. And 2 folks are on one or other of my advisory committees, on a consumer advisory committee, on a technical professional advisor. It's been a really good group effort. And and I depend on these people highly to help keep this thing focused in the right direction. We are still very much a stakeholder organization, and we'll stay committed to serving the 5 communities. I'm going to zip this along a little bit here. Basically, I think the key things that I want to stress here is we do some things very important that are not done generally in exchanges. Not only do we centralize the data around the person, but we also standardize it. And that's incredibly important if you're going to do things like clinical decision support across institutions. One of the really neat things that's starting to happen right now is the ability for me to notify a care manager in real time, and I mean within a minute or 2, of somebody walking into an emergency room, of somebody walking into a hospital for admission, of somebody being discharged from a hospital, and hopefully for Lisa's case, somebody being discharged from a long-term care center, the ability to start to bring that care team tools so they know where that person is moving through the structure, can support them and guide them as it's happening. That's something which we're just starting to see start up today. The automated nature. I see the person moving through the structure. I see them in real time, and I can notify a care manager when an event occurs. I can notify a provider when an event occurs so they can intercede early and get engaged with a patient. That's really, really terrific in terms of where it's going. Let me skip down to some things. So basically, where are we today? Basically, we're just a little over 1 million lives. Take a few 100,000 or 100,000 out for people from away. We are an opt-out consent model for general information. I'm not going to dwell on that a lot today because that's really not my mission to dwell on it. But basically, we are in a situation where people who do not want to be in need to indicate that they do not want to be in. And if you do not want to be in, we remove your data. I'm the only exchange in the country that I know of that actually removes your data. So that's kind of fun. What's really interesting here, though, is we're starting to get to critical mass. Right now, there are 25 hospitals connected, but there are currently 35 now, as of yesterday, under contract. 35 to 39. It's really 35 out of 37 because the other two, one's the rehab hospital here in town, and the other one is Spring Harbor, which is actually coming in under a different relationship. So we're down to 2 hospitals. That's it.
And basically, by the end of this year, that 34 will be connected. That represents 92% of the activity that's hospital-based. We also, quite frankly, have a significant commitment and connection to physicians' offices and the FQHCs, which is very important. The goal for the state of Maine is to have 80% of all providers connected into the exchange by the end of 2015. Ambitious, but doable.
Oh, Deb?
Yes?
Thinking of Beacon, I would just mention, think of
We are not part of that, but the Beacon funds development infrastructure, and East Maine Home Care and two of our nursing homes will be the pilots that will create the infrastructure, get transporting, put the information in the net, and then once we've developed it, that will be the state.
Right. So I want to jump past this, but I don't want to ignore this. Very important thing happened last year. After some really diligent work, the concepts of trying to make sure we don't discriminate against people who want data in, particularly in sensitive areas, and working with Jen and her group and a whole bunch of folks in the mental health arena, making it so that the information can come to the exchange, be sequestered, and then if a person wants it exposed, have it exposed. That's behind this whole thing, and it's really quite important. And we're struggling. It's very hard, not just technically, just getting our hands around it in terms of what we're doing is challenging. But I'm really hopeful. Maine is one of 5 states that is currently under a contract with SAMHSA to actually integrate the behavioral health community with the general medical community to the best of our ability. And I'm very hopeful on that front, quite frankly. So I want to touch the last 2 slides. Yeah. Go ahead. Yeah. So here are some opportunities. I've already mentioned Beacon. I think we need to, as a state and as folks in this room who are interested in health, we need to dissect this project. We need to learn from it. We need to do what we can do. Not every community is the same, but there are fundamental lessons in this thing that will make a significant difference. I think basically we're also now looking at how, that care team thing I'm talking about, how can you have a ubiquitous, secure messaging structure so that a team can behave like a team. This is going to be a fun adventure over the next year and a half, 2 years to make this go. Also, quite frankly, it's imperative that we focus on connecting those communities that got left out. When they did ACA and they brought all these incentives in, they kind of, actually it was high tech, they kind of forgot, I don't know, behavioral health, long-term care, home health. No incentives there, and yet those are the very structures that are actually foundational to helping us drive improvement and reduce costs. So clearly we need to do something about that. And I think the public health system is something we should probably not ignore. It will be the fundamental building block for us actually seeing opportunity for investment and driving change. And again, that big data thing, that's what's going to allow that group to actually do some things that are effective and important. Now, I also think there's some serious challenges that we need to be dealing with. As I said, there's inequity in the structure today. And again, technology without incentive, not such a good thing. So that inequity we need to continue to address. It's not a great time to be asking for more money. It's not a great time for government to think they're going to spend money. But if you have particular sections that are truly disadvantaged because they're not being encouraged to change, then you're going to end up with some big holes. So I think that's something we need to stay focused on. I can't say it enough. If we really want to change things, somehow we get the consumer patient involved in this thing. I don't know how. But those social networks, that ubiquitous 24/7 connection thing begins to open up some areas
where that may actually become why I play, because it's actually part of a larger thing, you know. It's amazing to me how much gaming actually is the foundation for engagement. So can we come up with some games that actually engage in helping do better with health? That's a crazy thought, I know. But that's what the marketplace is being driven by, is gaming. So, hey, that's good. And then I think we have some serious legal and cultural obstacles to overcome. Our first adventure into the mental health, behavioral health, HIV community, in terms of trying to gain confidence and not discriminate, at the same time recognize and respect individuals' choice, all of those things are played out against the background of the cultural environment that we're in. And I think if we're really going to truly transform this thing, we got a few serious issues that we're going to have to work through at a cultural level before we're actually successful. So I want to get Ralph up here, but I'm going to stop there, and hopefully that at least gives you a framework to start thinking about what we might do.
Great, Deb. We are so fortunate here in Maine to have the the level of talent that we have here in our speakers and around this table today. And last but certainly not least, Ralph Johnson, one of the foremost health technology pioneers in the country. And Ralph will talk to us about
pass off the microphone.
You mean you don't want to hear me eating my sandwich?
And how it can benefit the rural consumer. Take it away, Ralph.
Thank you, Earl. And I don't know how I live up to that introduction, but I'm not going to give you my resume or anything, but one thing I think is important for you to understand is that 6 years ago, I actually was up here on the Hill. I was the CIO for Maine Medical Center. And I made a quality of life choice. I had grandchildren on the way and just had this wonderful opportunity to come to a rural community and bring some of those skills. And I got to tell you, I love every minute of it up there. Franklin Community Health, and what I'd like to do today is just sort of walk you through one implementation of some of the technology we've talked about, and then just I'll briefly touch on a few other examples for you. Franklin is a small rural hospital. We're a sole community provider, which means we're the only hospital in Franklin County. We cover an area about the size of Rhode Island that has a population of only about 40,000 people. We also have 11 physician practices that are part of the hospital, which actually positions us very well for some of the other things we've talked about. There are other independent practices in the community, including 4 FQHC practices from HealthReach. The hospital also has a public health agency called Healthy Community Coalition. We run the ambulance service for Franklin County. We have a crisis service. And probably very pertinent to today's discussion, 5 years ago, we applied for and received an FCC award when they were offering rural health care broadband awards, and we received $3.5 million. We opted, if some of you have heard of NETSI, the New England Telehealth Consortium, we opted not to become part of that, did our own project. We actually put it to rest about 2 years ago, and brought a large amount of broadband to the community, which was so important to some of the things we do. I described that, basically the breakdown of our practices, but it's heavy primary care. We have 3 primary care practices, internal medicine. We also have a pediatrics, plus we have some special. And this is part of what drives me. There's two important things. Lisa actually touched on this a little bit, but for me, medication errors are the preventable errors in our industry. They probably cause some of the greatest amounts of the reasons for hospitalizations and a lot of the care problems we have. So we actually tried to tackle that by bringing out e-prescribing. Now, at the time we did this, we did not have an electronic medical record in our practices. We were approaching this as sort of a precursor to bringing an electronic medical record to them. The whole concept, if you understand, is that the provider writes the prescription in the computer, the order is signed electronically, the tool ensures that the order is complete, and some of this was touched on earlier. we had to really work with the doctors because doctors like to count clicks. How many clicks does it take me to do this when, you know, it takes me 17 clicks to write this prescription when I used to be able to just write it on a piece of paper and hand it to the patient. Well, what we had to convince them of was the totality of their day and to help them see that they weren't getting that phone call from the pharmacist 2 hours later and there are three patients later and now trying to remember because the pharmacist is saying, do you know that their insurance won't pay for that prescription, or do you know that they're also on this other med? We also bring into this some clinical decision support, which the technology brought in. So we started introducing drug checking, drug allergy checking, drug problem list checking, and legibility issues, and starting to eliminate some of the problems we had. I like this one. The games doctors play is what it's called. There's also a convenience for the patient when we did this. The order is checked against their insurance plan ahead of time, so they know what it's going to pay for. The doctor will get alerted when they're writing the prescription that, do you know it's not going to cover this, and recommend substitutions. The orders go directly to the patient's pharmacy, so now the patient has a convenience, but they leave the practice, they show up at Rite Aid, and the prescription is ready for them. They're not going to Rite Aid, handing over the handwritten prescription and waiting 10, 15 minutes for it to be filled. When we did this, we actually convened a large group of people, including all of the primary care, or all of the physicians and providers in the area. We have health reach practices, I said earlier, in the area. Our practices, there are 4 independent primary care practices in our town as well. We also brought in the ophthalmologist. We have an independent orthopedic surgeon. And then one thing that we learned within a few months is, you know, these aren't the only people writing prescriptions. Dentists are routinely writing prescriptions too that can cause the drug interactions. It posed some problems for how we did this as far as the grant, because most of the dental practices are for-profit, but we approached them. They actually welcomed us and they came into the program too. And so what did we accomplish? We were able to lower prescription costs for patients. 98% of the prescriptions that we write automatically default to that a generic can be substituted. The technology allowed us to do that. The physician didn't have to check the box on the prescription pad, and if they're in a hurry, they're going to forget to check that box. And even now, we have 8 prescriptions a week that are changed because there's a warning to the physician that says the patient's insurance isn't going to pay for this, and they change the prescription to something else. And we still see, this is years later, we still see 25 prescriptions a week changed because of drug interaction warnings. So the technology is catching these potential errors, alerting the physician, and the physician is changing that order. When we first started, this was over 50 a week. So that's the e-prescribing. There's a couple of other things we've done. We've been fortunate to be able to do in Franklin County. And I think one of the things I want to emphasize is none of these were because we got multi-million-dollar grants. These were things we did as, you know, part of our budget, part of our rural healthcare setting. We implemented a few years ago bedside medication verification. Stays on that theme of medication errors being one of the biggest problems. We put a barcode reader in every patient room. Patients receive a wristband, as they do in any hospital, but it has a barcode to identify the patient. And when the nurse comes in to administer medications, they scan the patient, brings the patient's profile up on the computer screen right there in the room. The nurse scans the medication that she's about to give the patient. It verifies that it's in the medication list, and it documents that she gave that medication. It does what we call the 5 rights. we saw results of that in 3 hours. I remember I was up on the nursing unit when this happened, when we activated, and one of the nurses started saying, this system's not working. It's beeping at me. And so we went into the room, said, show us. She scanned the patient, it brought the profile up, and then she scanned the IV bag, and it did this double beep at her, and she said, see, it won't work. It won't scan this bag. And we pointed her to the computer screen, and it said, not for this patient. And she suddenly turned white and said, oh my God, I almost hung the wrong bag for this patient. So she was our believer. She's now one of our biggest champions. Another technology we did, this is fortunate because of the broadband grant, but we are part of a PAC system, which is picture archiving. It's basically the radiology images. Maine Medical Center actually hosts those images, and they do it for many organizations, not just Maine Med in Franklin or just the Maine Health Hospitals. There's a lot of organizations where they archive those. And there's advantages to that because you can see prior studies, which are important in some cases for physicians to see what did that ankle look like 2 months ago or 3 months ago when another picture was taken, and it might have been taken somewhere else. Before we received that broadband grant, we would take a CAT scan. And we're fortunate we have a 64-slice CAT scan, which is a pretty high-end, but it's also very data-intensive. If we put a patient, a trauma patient, into a life flight helicopter at Franklin to send them to Lewiston for a trauma surgeon, and then at the same time try to transmit that image, there's so much data in that CAT scan, CT scan, that the helicopter would land in Lewiston faster than we could send that image through the technology. Now that we have the broadband in place and the connections, the trauma surgeon's looking at that image before the patient even leaves the emergency room, is even loaded into the helicopter. So it's made a big difference for us. A quick piece on telemedicine that we also do. Leapfrog and other groups are really pushing for intensivists. They're a highly specialized physician that work in critical care units. And that having an intensivist cover a patient improves outcomes. The problem is, as I'm sure some of the organizations know, intensivists are very hard to recruit. They're very expensive resources, and you got to keep them busy. We've got a 5-bed ICU. What we did in 2008 is we implemented an electronic ICU with Maine Med. So over by Andover College, right down here, they've got doctors and nurses in a bunker, and they're watching patients at, I forget how many hospitals now, but over 200 beds where they're watching the telemetry data coming in for all of those patients. They're rounding on those patients. There's actually a camera in the room that with the physician's, on-site physician's permission or the nurse's permission, they turn on the camera. They can actually help monitor that patient. We've actually seen some results of that. We have, again, we're hours away from sending those patients to a hospital that has intensivists. Many times now, those patients don't have to leave the community. They can stay where their families are and stay in the local hospital rather than traveling to Lewiston or Portland or sometimes Bangor. And what we find is with the level of care they're receiving, the length of stay is dropped, which means they're going home sooner. And then pretty close to the last for me as an example, Deb already talked about Health Infonet, but I'd like to just touch on some of the impact it's had for us locally. Our clinicians, and I emphasize clinicians, not physicians, use Health Infonet routinely. I think our usage rate almost rivals Maine Med's for the size, because one of the things we did, we were an early adopter of this, was realize that that data needed to be in the hands of everybody that's caring for that patient. So we brought it to the nurses early on in the emergency room, in our outpatient settings and other areas. We were the demonstration site to demonstrate that a small, rural, independent hospital could be part of Health Infonet. Eastern Maine was part of that initial, Central Maine, Maine Health was part of it. And then Deb brought us along just to prove that it could be done, so that when he went out to the other hospitals, the other small hospitals, he had somebody who could say, no, it can be done. So one of the most important statistics for me that I emphasize at the hospital all the time is there are about 45,000 patients in Health InfoNet that have a medical record from Franklin. 48% of those patients, almost half of them, have a medical record number somewhere else, which means 1 out of every 2 patients that walk through our door, there's something in Health InfoNet, and somebody should be looking because it might be relevant to taking care of that patient beyond what we know in the walls of our hospital. We have a lot of success stories, but the only one I'll touch on is one of my favorites. We started to notice that, because I get statistics from Health InfoNet, that our oncology nurses started being some of the biggest users of Health InfoNet, and it didn't make sense to us at the surface why that was happening. So we went and we interviewed them, sat with them to find out. And what we found, and this is pretty routine, is that the oncology patients, not necessarily our oncology patients, but an oncology patient would show up in the emergency room with symptoms, problems. They're nauseous, they have a headache, or different problems that are causing them a lot of distress. The ER docs are not oncologists, and they know these patients are receiving chemotherapy or radiation therapy, sometimes both, and they're nervous to treat this patient and interfere with their oncology treatment. So what they would do routinely, and this was even before Health InfoNet, they would turn to the oncology nurses who would gather all the information they could and create a profile, give it back to that emergency room doctor, and then they would have some confidence in how to treat that patient, what they came to the emergency room for. Well, it took a matter of weeks for our oncology nurses to realize if they go into Health InfoNet, they were getting immediate access to the Alphon Cancer Center, Maine Center for Cancer Medicine right over here in Scarborough. And they were able to quickly pull together this profile. They started just routinely using it when these situations occurred in the emergency room and creating these profiles for the physicians. And it was like, it validated my argument that we needed to go beyond the doctors to give this, give access. Did I get you back to go?
You did good.
Very much so. Stay up here. The next part of our program, we're going to focus and try to have a panel discussion around a couple of different issues. The first being privacy and security, and particularly, to give the patient a good feeling and knowledge that that their records are secure and they're confidential. So that's one area that I want each of our speakers to talk about in terms of their particular hospital or organization. So that's number one. And the other area is, and Deb talked a little bit about it, and that is the area around policy, around the Affordable Care Act. What seems to be working well with it, what doesn't seem to be working well, how that impacts your particular organization here in Maine, and where you'd like to, perhaps see, for potential opportunities and suggestions as far as moving forward. What policy areas would you like to see addressed, A, state level, and B, at the federal level? So first, I'd like to ask Ralph to talk about security, confidentiality at Franklin, and then we'll get the discussion going.
Yes, we have some. No. No, it's an interesting dilemma because we're always challenged with this around the security and the privacy role for the patient. versus our need to care for the patient. I mean, we have all the policies in place, the HIPAA policies, and we enforce them pretty heavily. We take them seriously. The challenge we run into are some of the things within the state. So I'll give you a good for instance, and this is one that's difficult for me. Always a challenge for me is around not substance abuse, behavioral health. For so many years, all the protections around behavioral health, we exclude access to those records to everybody else. And this goes back to the discussion about caring for the head or caring for the body. But when I speak directly to what I spoke about earlier, medications and medication interactions, it's always bothered me that we exclude those medications for behavioral health that potentially could harm the patient with interactions that are happening on the medical side. So to me, that's a practical example of where there's a conflict on security and privacy of these records. Luckily, and Deb didn't touch on this, but LD 1330 last year actually changed that for us within our organization, that allowed us more ability to share those medication records amongst our strict behavioral health providers with our primary care providers. We do that with full disclosure with the patients and explain why. But because we're all under one payer ID and we're a provider-based organization, we're able to share those records legally. Again, we put our own safeguards into that, but that's how we've tried to address that problem. But we still have the other primary care providers in the community that worry us.
Talk a little bit about the actual, from a technology point of view, and you don't have to get into the deep technology, but from a technology point of view, why should we feel secure that our records at Franklin are not going to get hacked into, you know, et cetera, et cetera?
That's a hard one, because there's certain aspects. I could give you statistics of how many people we've reprimanded or fired. Yeah. But there are HR policies around the fact that I can't talk about those. Right. But we routinely do enforce our policies. I do routine audits. So you know, a good example, I just spoke about the behavioral health records. And while we're allowed to share those, we needed to build in some assurance for the behavioral health providers and for the patients that we take it seriously, that nobody's abusing that access. We're doing this for their care, but not abusing access to those records. So one of the policies I actually put in place was that I routinely, every week, I randomly pull 5 behavioral health records myself. And I review those records to see who has accessed those records. And then if they are not a provider of record with that patient, I open a privacy investigation, just like I would with any other. As a HIPAA privacy officer, I routinely have to open investigations in other areas, and I would open one that way. And so it was a way to actually assure the behavioral health community that we were putting a heightened awareness around making sure. I can't audit every record, but we randomly pick 5 every week and make sure that they're not being abused.
Deb, would you like to talk a little bit about you know, your policies and as well as technology?
Sure. It's interesting, in the lead up to Health Infonet actually going live, we had a very robust debate through what is now called the Consumer Advisory Committee. At the time, Carol was on that group and had not come on it yet. And in that discussion is a natural tension between the uncertainty and concern of the consumer. It's sort of like investing. You know, how much risk are you willing to take, and how much do you really care? And each of us have different risk tolerances. And the natural inclination of the provider to want to see as much as they can, ideally everything. And that tension is what gets played out for your policies and your strategies. At a technical level, because I'm a lightning rod, I'm doing something which makes people uncomfortable. I feel that we have to manage the exchange at a level technically that goes beyond what is standard practice. So a couple of things. First off, I'm the CEO, but I'm also the privacy officer. And that's done on purpose because I think that the single most important role I have is to build that confidence and maintain it. So I actively am engaged in the actual day-to-day audit, review, assessment, et cetera, of risk. And so that's what I do a lot of my time around when I'm not out doing these types of things. Secondly, we took advantage of technologies that are new. And today, the way the exchange is built, we physically separate the data set that is the identifier data set from the data set that is the clinical data set. So those two sets of data live physically in different universes. And we then encrypt those structures at rest, which is a very important step, and that will become a standard practice across the industry within the next 5 to 10 years. You'll have to do that. And we obviously also encrypt that and it's in motion. Either that, I don't assume I can't get hacked. But what I'm doing is trying to make it extremely difficult, if I do get hacked, to take the identity and put it together again with the relevant clinical information at a specific person level. And it only gets created and reassembled on demand, and it's what's called a web service call structure. It's done inside the structure, and you'd have to be a very creative hacker to figure out that web service structure because it's very unique and different. So at a technical level, that's what we do. We also have some policies that I think are really important. For example, twice a year, I pay someone to hack me. And these are good people. These people, you know, this is like going out and hiring your 12-year-old neighbor, actually. But these are people that do this for a living. They you know, sometimes they're sort of dark. You don't really want to know what they do. But it is one of the most rewarding experiences because they're there to break you. They're there to find any and every possible way they can in. And it's kind of like going through an audit. It's a good thing when they find something, because that's showing you where you got a hole. So, case in point, we just went through our semi-annual event, and we don't know when they're going to do it, by the way. We have no idea. We pay them to do it, and then all of a sudden we wake up one day and all these alarms are going off, and it's very entertaining. But they found a hole in what is called a virtual private network. They found a hole in our virtual private network that the manufacturer, Cisco, had not seen. And you know, it literally, it was amazing. Somebody was able to spoof their way into our, they were able to spoof their way into our virtual private network, and it was a problem in the Cisco product that Cisco had not picked up yet. So it was one of these like, woohoo, great things. But so I think it's very important to be as aggressive as you can to try and find your holes and your weaknesses. You got to do that. And then a couple of things that are really important. And this is that compact thing with the patient. One, inform the patient and inform the user that you do audit, and that you make that audit available anytime the consumer or patient wants to see it. So that's a very strong message back to the users of the system. Pay attention here, because if somebody wants this, we will give that information out very happily. And secondly, put into place some audit structures that look for common bad behaviors. Let's just put it that way. Our problem is not so much the hacker. They're a risk. You can build very solid perimeters. You can build very solid tools for intrusion detection and management. You know, our ports get hit hundreds of thousands of times a month by people just looking, just pinging, just hunting. And that's good. You've got the perimeters up there to make that happen. My largest single threat is not that hacker. My largest single threat is my authorized users. I'll give you a case in point. One of my audits just last week popped up something that was unusual. So I do the audits. So I pulled this, and this is one of these things that really breaks your heart, because the person is doing the right thing, they're just misusing the system. In this case, it's a doc, and she has a very frail mother. She's not her mother's provider, but she's using the system to follow her mother's care.
And that is absolutely not permitted in policy, because her mother didn't sign anything to say, yes, I give you permission to release information to my daughter. So here's a classic case where this individual is going to get sanctioned. And this individual institution's sanction policies are rather harsh. And yet your heart knows that she was doing the right thing, but she was absolutely violating her policy and training. And that is not uncommon. We see that sort of thing all the time, and that's what I think causes consumers, patients, whatever you want to call them, to be uncomfortable. Because it's the very people you're trusting who have the authority to be there who then do stupid things. You know, they look up their ex-wife's data, they look at their neighbor, because he's really a good guy and he's a good friend, I'm just going to see what's going on with him. I've had these conversations with providers and they look at you blankly, what's wrong with that? So that's where the risk is greatest. I would argue 90% of the time, maybe even 95% of the time, it's not even done maliciously. It's just, I've got the access, I've got the interest, and I'm not harming anybody. And so I think again, that's what whittles away most at the trust fabric here. Yeah, the hackers are there. Yeah, they're dangerous. They want two things, really. They want monetizable data. So the highest risk thing is they're going to go after is the insurance, because then they can, you know, use the insurance policy illegally, which is the single largest growing thing right now in the healthcare, by the way. The other thing they want is fame. You know, neither thing with healthcare data. Healthcare data by itself ain't worth that much. I'm sorry, it's not that exciting unless you're a celebrity. It really isn't that exciting, and quite frankly, it doesn't monetize very well. So those two things by of themselves make it less attractive for me as a hacker to spend my time on them. I'd much rather go, you know, hack credit cards and or brag about being able to break into the Department of Defense, because that's really cool shit. You know, go out there, get your cred, and that's a lot of what that's about is the credibility of being able to say I'm cooler than the next guy. So quite frankly, we pay very close attention to that universe, but it's not really where our exposure is. And our exposure is in that authorized user group and in trying desperately to have them understand what good behavior is, not because they're bad people, but because it's there and that's what they do for a living. And that's the real challenge.
Very good. Go ahead. I was just going to ask if you can talk a little bit about the patient side of things and patient access to their data.
Yeah, back in 2005, we committed to provide a way for patients to get at their data. And this year was the year we're supposedly bringing connection to that data. And this is one of those wonderful things where technically we're ready to do it, and then the impact of something like meaningful use comes along. And for those of you who don't track meaningful use, it's really quite an odyssey. But the second stage of meaningful use, which is now being finalized as far as rules, has dealt us somewhat of a hard blow. And that is, they've tied the concepts of scheduling, refill, et cetera, so tightly to the EMR that for an independent like Health Infonet to stand up and help support the providers with a portal or PHR that will also support meaningful use, actually I'm superfluous, because I can't do those things as well as their EMR vendor can do as far as connection. So now we're in this dilemma, what do we do? Because, you know, Lisa's organization isn't going to invest twice. And so basically now we're starting to pivot a little bit. And the question is, how can I get the statewide data available through Lisa's portal strategy so that that patient can call for it even though they're inside of the Eastern Maine portal or they're inside the Maine Health portal. And it's a developing concept called Blue Button. Don't waste a lot of time on that concept. But basically the idea that I can expose the statewide picture of the person even though they're inside of one of the provider's structures. Now what that unfortunately does is that the smaller, less invested organization is kind of getting robbed of what I was originally hoping was going to be a shared service concept, because meaningful use is driving us down a track that says it's so tightly tied to your EMR that you're going to invest in what you have to be in compliance. And that's kind of one of the sort of sad outcomes of meaningful use. Now, I can understand it, but it's a little disruptive. But yeah, that intent is to actually begin to make that content available here. And quite frankly, today, anybody who wants an audit, we will generate an audit for them. Frequently, that also creates some interesting tensions because you see all these names and you say, who the hell are all these people? And you have to spend time explaining that you've never met the MA, but she did all the work prepping your chart before you had your office visit. You don't see your doctor's name on here anywhere, but the MA did all the work. And so you begin to introduce people to the underbelly of how healthcare gets delivered. But yeah, the objective is still to make that data available. It's just we've gotten thrown a little curveball that we're now having to work around a little bit.
Kevin's got to leave shortly, and I want to call on him to make a comment either A, on the issue of confidentiality and security, and/or if you get any comments around ACA and health policy.
Nice, narrow, tight question. Well, one thing I'd say on confidentiality is just to pick up on Dev's comments and something that he's presented on in the past that I wanted to make sure to get out on the table is I think in digitizing all the information, there's a lot greater security and ability to follow the trail or identify who's got access and who doesn't, as opposed to the paper charts, the paper records that where anybody could perhaps sneak in and gain access. So I have a lot more confidence as a consumer and in terms of confidentiality with the move to digitalization. ACA, the most common question I get is what happens if the Supreme Court throws out the individual mandate or goes further and throws out other aspects of the Affordable Care Act. I think the individual mandate is probably what most people are guessing is really on the bubble. So let's assume that it is thrown out. Well, certainly the co-op is subject to some potential disruption in terms of individual mandate flowing to a less robust exchange, and that's a health insurance exchange in this case, which changes our enrollment strategy and projections. But it doesn't alter our course in terms of providing a nonprofit health insurance solution for Maine and really being a competitive driver and offering that alternative to what's out there now, especially in the individual market, which is just so lacking in terms of value. So, I am committed to proceeding. If I weren't committed, I wouldn't have left my job. So, in terms of the IT angle, it's almost like a symphony of sorts. About the music genome, Dev, but we have all these things that have lined up in terms of where we have come, and the ACA really plays well on the ERA and the High Tech Act, as well as the earlier work that Maine, Dev and Ralph talked about, and Lisa, in terms of the infrastructure and the environment we have. It syncs up so nicely. So my worry is that folks are going to get lost in the weeds of political positioning and not realize all the good that can be had with this current setup, and really taking the Beacon Project, taking Patient-Centered Medical Home and the Health Homes Initiative, the value-based purchasing of the state as it plays into that. You deconstruct the ACA, and I know I'm preaching to the choir here, I suspect I am, but people on the street tend to say, yeah, that makes sense, yeah, that makes sense. Just the rise of accountable care organizations in Maine, where we have potentially 5 between the Pioneer, that's the Beacon effort, the Central Maine, Maine General, Maine Health, Medicare Shared Savings Programs, and the FQHCs that combine to form
unaccountable care organization, we've got really some significant, getting back to Dev's first slide, possibilities for disruption in both the payment system and together that will be sustainable. So we'll have to just see how it turns out on a constitutional basis and roll with the punches, I think. In some ways, the genie's out of the bottle, certainly with the ACOs, certainly with what we see as needing to change, how we can best provide services in rural Maine. And so the challenge is going to be up to us if the individual mandate makes it that much harder. I mean, if the loss of the individual mandate makes it that much harder.
Do any of you have any questions for Kevin? If not, Kevin, thank you so much for coming.
Thank you. We'll get us
Really appreciate it. Lisa, I'm going to ask you to comment next, please.
Okay. So first on privacy and security, what Deb talked about is, the reality of the risk management with an electronic health information environment. It's not the hacker, it's the provider surfing around for the right reasons in a record they shouldn't be in. So our system flags that, and a very aggressive notification and progressive discipline policy. That's pretty standard. What's unique and challenging are two different areas around security. The nurses in the field with their laptops, because it's not cost effective to have a nurse travel an hour back to the office to store the laptop in the office all night. So how do we have policies and procedures and security measures to make sure that the laptops that are all nurses carry, all therapists carry, and the home care aides are going to have a different technology, is secure? And so certainly, we have policies and we audit and we send supervisors out with the staff to audit around, when is that laptop activated? Is it safe and secure and shut down when it needs to be? And then also monitoring access to our electronic health record off hours. Staff should not have their laptops open at home documenting at night. They need to do it in the patient's home. So we routinely look at who's going in and out of our electronic health record, and they're not on call. And that also can result in progressive discipline. So that's a different challenge when we don't control the environment. Another challenge that we're sorting our way through, and it's with the Community Care Team project. How do you engage community partners in health service delivery, documentation of health service delivery, where they traditionally have not been part of our health record in the past? And so our community care team works very closely with the Healthy Maine Partnership. The asthma nurse with the Healthy Maine Partnership program really is the asthma nurse for the pediatric patients for the community care team. We have the Eastern Area Agency on Aging as part of our community care team. So we're using secure messaging, secure email on how do we communicate out to those partners in a safe and secure way? How do we communicate back to the community care team in a safe, secure way? And then within EMHS, we own that electronic health information, and then we securely place that information back in the patient-centered medical home chart. So that's a different challenge that we're kind of paving the way to sort through. As far as the Affordable Care Act, well, before the Affordable Care Act, there was one challenge that came up. We received a grant from CDC in Atlanta to do emergency preparedness planning for home care, hospice, and long-term care in 9 counties in Maine. And it was, we've just completed the project. It was a 2-year project. And one of the challenges we've identified is if we have a disaster, but it's not a statewide declared disaster, it's a local disaster, maybe like the flood in Fort Kent, and we have to evacuate. How many laws are we violating when the home care nurses call around to the various shelters saying, is Deb Culver there? Is Lisa Harvey McPherson there? I'm trying to find my patients. And so that's something that came up in the course of this grant project that we need to address, and that would be a state policy level, I believe, to address it. As far as the Affordable Care Act, we are one of 32 pioneer accountable care organizations in the country. And so we are asked a lot, what happens if they repeal the Affordable Care Act? The train has left the station on redesigning healthcare delivery. We have entered into a 5-year pilot agreement with CMS to begin with shared savings, transition to shared risk, and move into a population-based capitated payment methodology. And so I asked at one of my briefings a week or so ago with AHA this very question: what happens to the 32 pioneer ACOs who have contracts with Medicare for this pilot project? And the sense was that Secretary Sebelius has broad statutory authority to carry these programs forward even if the law is repealed, and that she will do that very quickly. So I have a sense of comfort that it's on their radar and that the regulatory environment can right-size to support the provider environment, because for about the first time, the provider environment is out ahead of the payers and the regulatory environment. And so we need to make sure that everyone can keep up.
Great. That's very, very good comments. And the Supreme Court, being lawyers, understand that contracts have to be adhered to. It's, it's part of the sacrosanct part of our whole system. Contracts and the enforceability of contracts are extremely important, and there's absolutely no way, irrespective of whether a law is constitutional or not, that the Supreme Court can come in and in any way affect, a lawful contract. So I think folks that are engaged in and have contractual relationships with the government based on ACA should feel very confident that all of those will continue.
Earl, I saw something a couple days ago which was interesting. The question not only was what's the impact on the providers, but what's the impact on the committed funding streams. And there's about $15 billion associated with ACA, and the analysis I saw a couple days ago said about 5 of that is at risk.
There you go. Which, there are a lot of different ways to recoup that, and I'm sure, even though Congress has had a hard time acting in unison of late, again, those kinds of issues that come up, particularly issues, speaking of the AHA or the AMA or whatnot, that would affect their constituent members, particularly the lobbyists and folks in D.C. haranguing the congressmen and senators to say, you need to fix this thing if there's an issue. I think there's a pretty good chance, particularly in an election year, you're going to see any issues around that if certain, whether it's the mandate itself or other aspects of the law are struck down, I think you're going to see pretty quick action to get it fixed. As an audience, do you have any questions or comments about what you, please go ahead.
I do. This has been really interesting to me. And I work here at the IRIS Network, and we do rehabilitation with people who are visually impaired and blind. And we have 2 departments here. We have a database system. And we have a low vision clinic that accepts Medicare money, and there's medical practices in there. They're HIPAA compliant, and our vision rehab services, which is a rehab model, is not HIPAA. It doesn't have to be HIPAA compliant, but we certainly try to follow the guidelines, but the signatures and everything. But we are on the same database, and the clients that we work with, anybody who has access to the database has access to the records. So I'm not asking you to answer anything, but it makes me think that we have some very serious security issues by having somebody who has Medicare HIPAA compliance being on the same database with those of us who don't, where his confidentiality issues are probably a lot stricter than ours.
It's interesting because now you're into what I would call the question of you may not be violating the law, but you may not be meeting the moral standard of practice that makes you comfortable. And I guess my general reaction is, my general reaction is that you ought to ignore who insures the person and think about the concept of what's the minimum standard of data management that makes us comfortable. Obviously, you cannot violate HIPAA, but I'm not suggesting that even HIPAA is a significant enough standard to work from. HIPAA's pretty loose. I mean, that's the floor, not the ceiling. So I'd ask yourself some questions in terms of what is an acceptable standard of practice that makes you believe that you're serving all clients well, and don't get so wrapped up in what the insurance program is.
Thank you.
If they're taking care of the patient, they have a right to see it, no matter how they're employed or
That's another key point. Maine's medical record laws are such that, at least for hospitals, they must provide the record. Now, they can choose to ask for a surrogate to read the record because they deem that it might be dangerous to you, but it must be the record in its complete and original form that's provided. I don't know if that applies in your situation because it certainly doesn't apply to office practices. Office practices are only required to provide a transcript of the record. So, but it is still supposed to be accessible to the individual.
There are countries in the world, I believe, where virtually everybody has an electronic medical record. Are there lessons that we can or have taken from those countries in terms of security, or is it just not relevant?
Yeah, but you bring awful names like socialism and other things on the table. I mean, the countries that have done the best here are places like the Scandinavian nations in particular have done extremely well. Taiwan, it's a different strategy. It's a card-based strategy, but they've done extremely well. France has done actually quite well, but all those countries, because they have a socialistic medical system, have been able to enforce what I would call a single information standard. You know, the beauty of France is that you can go to any physician office and you will find no medical records because everything arrives with you, and he or she works from that, and everything then leaves with you. There are downsides to that too, don't misunderstand me, but the fact of the matter is that they have built a system. We do not have a system. We have a bunch of little systems, and that's the lesson that's learned there. Do we have the moral and legal courage to change? Doubt it.
Deb, are there any other multiple payer systems in the world?
Yeah. Oh, good Lord, yes. Germany's terrific. Germany. There are 280 insurance companies in Germany. The difference is they're all not-for-profit. Every one of them. We're the only country in the world that has for-profit health insurance. Very interesting in its own right. And their primary mission is to pay the bill. And they do it within a prescribed period of time, usually 2 to 3 days. Now, Germany has its other. I mean, Germany doesn't pay its providers well at all. But yeah, no, you can have real competition in the health insurance business. It's just fundamentally, you know, you go into a German insurance company, and guess what you don't have? You don't have 100,000 people dedicated to denying claims. And why do we deny claims? Well, because we're a for-profit entity, and that's how we make money. So that's what's perverse about our structure is that you've got incentives built in that are upside down. So no, you can have a very competitive insurance industry. They compete like crazy.
Other questions, comments?
Oh, I would just highlight one other unique benefit to Maine with having our health information exchange set up with Health Infonet serving the entire state is that many states have more than one health information exchange. And so Monday I was speaking at a national post-acute health information technology with the CMO from New York's health information exchange. And in the New York City region alone, there are 8 different exchanges. And so we are enormously benefited by just having one exchange serving the entire state. On the provider side, I cannot imagine the nightmare of dealing with 8 or 9 different exchanges.
It's funny, I do think that, like anything, organisms can only grow so big, then they blow up. And I do think there is a natural limit to what a single structure can and should support. And so the real trick there is to figure out how to put an umbrella over those individual pieces so you have some consistency across them. But I mean, I look at New York, I look at Texas, I look at California, I go, oh my God, what a challenge. It's one of the beauties of being small.
Lisa and Ralph, how would the folks that are here, in terms of the organizations that they represent, what kinds of takeaways should they, consider in terms of taking back to their organizations, and in terms of assisting them with doing their jobs better? Any suggestions?
I just wanted to piggyback on that. Because we're one of those sort of peripheral organizations between medical and case management. We have to get data from medical providers all the time in terms of like labs, report counts, all of that. But we don't have access to and certainly there were no incentives. So I'm wondering what kind of advice you would have for us.
We're really entering a very interesting, for the exchange's perspective, very interesting period of time because, yes, we've got the core objective of connection for treatment, and that's coming along pretty nicely. But we keep bumping up against, I would describe what you just described as an opportunity. We keep coming up against opportunities where there's friction in the system. We're spending additional money. The classic one is an insurance company comes to you and says, would you give me copies of your records, please, so that they can take those records, extract things they need in order to do what they do, and yet you've already electronically generated that information, and it's sitting somewhere electronically, and so now everybody's copying paper when the data's already there.
Right.
Huh? That's insane. So that's the kind of thing. We're at that point now where the trust is not total yet, but we're getting to the point now where the provider community begins to trust each other enough to be able to ask the question, is it okay then if we take the data and also use it to support legitimate review? Because that's a part of the process. And the classic one is disability insurance. That's even a consented process. Why wouldn't Unum come to Health InfoNet rather than going to all the different providers to have them generate paper records so they can do what they do? It's insane, and that's because we just haven't got that trust framework in place. So what I would suggest with organizations like yours is make yourself extremely visible to the very people you irritate, which is the guys you're getting the data from, and saying, hey, if you would just give us permission to access the data through that structure, we could all live a little happier. That's the kind of thing that we need to start looking at, because it's very legitimate. It confuses the consumer further, but it's very legitimate, and it's cost to the system, it's time to the system. And at the end of the day, why do we want to encourage that friction?
Right. And I wonder if the structure we're setting up with the community care teams, that secure email pathway, you're a perfect community partner for that secure email communication. But you're right, you've got to get on the radar screen of the people that you need the data from. And
we're on it in the annoying way.
In the annoying way, that's very good. Very good.
What's great is that you can get, they want to get rid of that annoyance. And it's really not that hard to expand the commitment to do that. We're just going through a cycle right now of updating from just treatment to treatment and operations to support the kind of thing you're talking about. So that begins to open up the opportunity to do that.
One of the things that we're embracing is that no matter what happens with the Accountable Care Act, we're shifting the whole model. We're going to get paid by the package, not by the piece. We're moving away. So we have to embrace all the other support organizations that care for that patient. And we're starting to recognize that in Franklin County. We're starting to work with Western Maine Transportation and the visiting agencies and some of the other groups, even the United Way.
I think the big opportunity for the peer service providers, those of us who are advocates and providing services to disability groups, is that, you know, part of the triple aim is involving us. And, you know, the medical model that we practice for a million trillion years does not involve patients. It's all about doctors doing something to patients. And so I think the opportunity for us now is to be involved in helping change this system into a system that works with us, not does to us. And I think, you know, that's sort of the new frontier, and I think there's no funding for that, and I think that's the biggest lift for the provider community, especially in my world where there's so much stigma. Why would we want those people coming in and telling us things when we think those people are really too ill to provide us with any useful information? So I hope I said that in a kind and friendly way. But I think there's enormous opportunity for us now to assist the system to transform in ways that are helpful to us. Because oftentimes the system transforms itself in ways that are helpful to practicing physicians, and they're not helpful to us.
It's really funny. This is where I see the risk-based concepts actually being an advantage, because you can't ignore the fact that you have such a high incidence of mental health diagnosis within the general population. You can't afford, under the structures we're heading to, you can't carve those out and not deal with them, because they're part of the bloody care. And for me, that's very hopeful. And I was sitting through a session a couple months ago, which you were saying was so wonderful. It was a doc and a mental health provider talking about issues with managing information and patients. And they started out in the first 30 seconds. One referred to it as a client, and the other one referred to it as a patient. Well, there's an interesting dynamic right there now, isn't it? And that whole discussion devolved from there around how you relate to patients and information management. So it's not only that we have irritants, we have a totally different view of the world in terms of those populations.
And the vocabulary and it's all totally different. Long-term care is residents.
Exactly.
You know, we're all talking about the same person. So, but I think certainly today we began to begin to focus on some of these things, and as we move forward and to in this patient-centered, focused manner, there's certainly many opportunities for all of us to work together and benefit from as well. I really thank you all for coming today. Particularly thank our speakers for coming, and again thank Lisa and Rosemary for putting this all together, and for Jim for hosting us. And unless you have any other questions, again, thank you so much, and we look forward to doing this again soon.
Thank you.